Wow. Good afternoon, everybody. It's wonderful having all of you here. Welcome to the School of Nursing. Welcome to this Roy Auditorium. I feel we are in a huge, big party here, celebration. Lots of friends seeing each other, haven't seen each other for a while, and we are all here for a wonderful purpose. So I am really absolutely delighted. I told Janet and the team we're not going to start this afternoon unless every seat is taken. So there is so much sense of enthusiasm in the room and enthusiasm about coming here. It's a very exciting moment in the history of healthcare in this country. And we are at the cusp of an incredible momentum. Lots of things are coming together to really move us forward. So we have a very thought-provoking program planned for you for this afternoon. But first, I want to acknowledge some people in this great, energetic, enthusiastic audience. First and foremost, I want to extend a warm welcome on behalf of all of us and on behalf of the School of Nursing to President Risa Lavizzo-Mourey. Thank you for coming, Risa. But more than that, thank you for sponsoring this fantastic report. Our second special guest is Dr. George Thibault, President of Josiah Macy Foundation, and thank you very much, George, for being with us here tonight. and for all the reports that you have produced related to this, too. Our third very special guest is going to join us via a video today, and that's Governor Rendell, who wishes he was going to be here because this is really dear to his heart, but he is in Pittsburgh today because of the Governor's Women's Conference. So I think it's a really good cause for him to send his regrets. I don't know. I debated whether I should accept that or not. I would like to also extend a very special thank you on behalf of all of us to two of our faculty leaders who are participating in this program and planned this program, Dr. Julie Sochalski, Associate Professor of Nursing, one of us, who has been newly named the Director of Nursing for the U.S. Health Resources and Services Administration, fondly known as HRSA. Bureau of Health Professions. So she's leaving us for a couple of years to do that. Thank you for coming back to your school for this program, Julie. And of course, Dr. Julie Fairman, Professor of Nursing, Director of our Bates Center for the Study of the History of Nursing, and the IOM Distinguished Scholar for 2009-2010. So this last year, which resulted in her direct involvement and being part of this report that's going to be discussed and launched today, the Future of Nursing Commission. And we are really so lucky to have had her being part of that, because what we're going to get a glimpse of the inside workings of that report and the future of what we should do. So first, please join me in acknowledging this wonderful group of people who are making this program. So now, looking at this audience and looking at all the distinguished people here, I probably could go on and on acknowledging each one of us. So let me just say in general that this audience is composed of presidents of organizations or their representatives, our Pennsylvania Interim Secretary of Health, Michael Huff. Thank you for being here, Michael. Dean's colleague from Philadelphia, Deans of Nursing, colleague deans right here from this campus, and vice presidents and presidents of health systems. Chair of our Board of Overseers, Rosemary Greco, is here, and other members of our Board of Overseers. And I see Ambassador Martin Silverstein right here too, but there might be some others I don't see because I see you all wonderful colors and mixture of people. And our dear friend and colleague, Dean Arthur Rubenstein, I think he is on his way here. And then, of course, our Dean Emeriti and great friend and very important person in our life, Claire Fagan. So presidents, deans, professors, friends, students, thank you all for being here for this afternoon. We are really honored to be able to bring together all of you, leaders and future leaders and shakers, movers and shakers, to first listen today to the recommendations of this really important report, then to dialogue about it, and then to act on it. And I think that's what the message will be today. So looking at the history of IOM, which is one of the co-sponsors, the Robert Wood Johnson and the IOM are co-sponsors of this commission and this report. This is, there was a first report on nursing in 1983. Which one of the outcomes of that report in 83 was the establishment of the NIH Institute of Nursing, National Institute of Nursing Research in NIH, which was a turning point actually in our science. This current report has the potential to make a different kind of impact, but a really bigger impact because it's coming on the heels of the healthcare reform and a number of other reports related to transforming nursing education and medical education. Fortunate for all of us, we have an amazing commitment from RWJ to lead the way, as well as a pool of all of us together to implement the recommendation. We need to pool our efforts, and I think they are going to help us lead the way in that. So now it is absolutely my pleasure to introduce our keynote speaker, Dr. Lavizzo-Mourey. Not yet. I want to say a couple of things about you. So I could tell you she is the president and CEO of Robert Wood Johnson Foundation. I can tell you about her incredible credentials and positions since graduating from Harvard, and about her stellar publications in influential and scholarly journals, and about her list of awards. I could tell you she recently climbed to the top of Mount Rainier in Washington, which is over 14,000 feet, and she's still with us. I could tell you that she really is one of us at Penn. She was the Selvan Eisman Professor of Medicine and Healthcare Systems and a director of Penn's Institute of Aging in Washington. But I will not tell you any of that. I want to tell you three things that we love about Risa. We love her enormous compassion for justice and equity, for the underserved, and for the marginalized, for giving them voice, for dedicating her practice to them, for driving the evidence to change policies that improve their care, and for making care more equitable for them. She chaired the first influential IOM report on health disparities. A president who continues, in spite of her schedule, to take care of patients at a community health clinic in New Brunswick. Because of her compassion for the underserved, she has the passion to increase their access to quality care. Therefore, she used the evidence from research that nurses and nursing care provides, that nursing and nursing care could provide the vital answer for increasing access and ensuring quality. She used that evidence to make a commitment to nursing. Therefore, the second thing we absolutely love about her is her passion for access and her commitment for providing nurses the support and the opportunities to be able to do what they know how to do best, which is take care of people and provide quality care. The third thing we love about Risa is her vision for the future. She is a geriatrician, always thinking of the future and of the next generation of care providers and scientists. A busy president, but a devoted grandmother. She keeps a kiddie carrier in the trunk of her car so she can be ready at any moment's notice to pick up her granddaughter and walk in the woods with her in her back carrier. They hike together, the baby riding high enough to grab the leaves of the tree branches. And that is how science grows too. The germ of an idea can grow until we have this enormously impactful initiative. So ladies and gentlemen, President Risa Lavizzo-Mourey, a president with passion, compassion, and a vision for the future.
Where does she get her information? That's what I want to know. Thank you, FF. I want to thank you for your friendship, of course, and your wise counsel, and all of the ways that you lead nursing, and especially for that kind introduction. I have to check on where you get your sources, though. And I also want to thank all of you for being here, because I believe that we don't spend enough time thinking about the urgencies of tomorrow. We all know we spend a lot of time on the urgencies of today, but now we're going to address one of the urgencies of tomorrow and the horrific price that we'll pay if we don't attend to getting ready for that urgency. This is the Institute of Medicine report that was released just 10 days ago. It's a report that you can download, and its title tells us exactly why we're here. The title is The Future of Nursing, Leading the Change, Advancing Health. If you go to thefutureofnursing, all one word, .org, you can download it, and you will see that it is not, as AFAS has already said, a sort of blue sky kind of report. It is very specific about what we need to do in the future. And on the face of it, you may think that this is a report about nursing, but don't be misled. It's really a report about fulfilling the missing pieces in healthcare's puzzle. Now, 2 years ago, when we proposed to the IOM that they make sweeping examinations of the future of nursing and tell us what the nursing profession would need to have us all do if we were going to meet the needs of the nation in the coming decades. The IOM accepted our challenge and put together a committee with our support to take on the task. Now, FF has mentioned that there have been other reports, but this was the first report that was truly independent, was put together by an authoritative group on nursing for quite some time. And the committee, just so you know, was made up of about 18 leaders from higher education, from economics, from health policy, from information technology, medicine, and of course, from nursing. It was chaired by Donna Shalala, who's currently the president of the University of Miami and the former secretary of HHS, and vice chaired by someone who needs no introduction in this audience, Linda Burns-Bolton. Now, the committee's charge was direct, and as I said, it was sweeping. The charge was, quote, to examine the capacity of the nursing workforce to meet the demands of a reformed healthcare and public health system. The IOM was to give bold recommendations addressing the delivery of nursing services in a time that where demand far outstrips our supply, to address the shortage of nurses in a time when we expect to see those shortages continue across the country, and the capacity of the nursing education system to meet healthcare's demand now and in the future. We were asking them to come up with an agenda, with a blueprint for changes in the public and institutional policies at all levels, national, state, local levels, and they took on the task. They knew what they needed to do, and they did it. Their findings are courageous, they're straightforward, and they're sharply drawn. And they're based on solid research and evidence. Their conclusions are already controversial, and that's because they're so consequential. I've studied the report, and the magnitude of what they achieved far exceeds our expectation. I believe that the report and its impact on nursing education promises to have a profound and lasting impact, much like medicine's Flexner report of 100 years ago this year. To me, It's nothing less than an operator manual on the future of nursing and how we're going to get there. Now, the committee concluded that the nursing profession has the capacity to implement wide-ranging change to make the health system better and the power to deliver on that better care. There's a big if, though. None of this is going to come about unless stakeholders like all of you, like us, come together in common cause to transform, not to reform, but to transform healthcare as we know it into healthcare as it should be and as we know it can be. And our foundation plans to play a role in facilitating the implementation of these recommendations. We see today's Pennsylvania launch as the first step in that process because it marks the defining of nurses' role in education and a huge milestone that we can take together to advance away from what has been America's long and troubled journey to better health care. To me, the job ahead is going to test our willingness for change. It's going to test our gumption. It's probably going to test our patience with one another. But I think it's going to be worth it. There's an African proverb that says, tomorrow belongs to the people who prepare today. So today, we have a chance to begin preparing for tomorrow, if we so choose to do it. So I'm here to tell you that I think that the difference between the way nursing was and the way it's going to be is in our hands. And I hope we will make it like the difference between night and day. Now, just in a moment, I'm going to walk through what I think all of this means for us. But first, let me give you some context to help you understand why we have the commitment we do. At our foundation, we've been looking forward to this moment for a very long time because going back, we have been working on strengthening nursing because it was a personal crusade of our namesake and founder, known as the General. And even though he was known as the General, he was never a man of robust health. He'd had rheumatic fever as a child, and that left him with many cardiac problems as an adult, and he spent a lot of time in the hospital. Now, this gave someone with the name the General the opportunity to sit with pen and pad and think about a prescription for how to make nursing better. So let me tell you what he wrote. Patient care comes first. It's non-negotiable. Next, we have to tear down the rigid caste and the silos that all too often are the enemy of hospital efficiency and prevent nurses from being full partners in the delivery of care. And finally, the General concluded that if we're serious about improving the quality of health care, nurses had better be a major voice in everything that has to do with that. Now, you have to remember, we're talking about a view from 60 or 70 years ago. That's why this is in our philanthropic DNA, and I have to say it's in mine too. What's stunning to me is how much has changed and yet how much has stayed the same, and yet how straightforward this prescription for improving quality of care and improving nursing and how it has stood the test of time. That's the General. My understanding of nursing came very early in my career, as Dean Fagan will know, when I was on the faculty here at the School of Medicine and at the School of Nursing. You've heard my specialty is geriatrics, and so I had the good fortune to practice in a team composed of nurses and doctors and other healthcare professionals. And when we would go out into clinical settings, we taught each other. We went to hospitals, we went to nursing homes, made house calls. We did it all, and our little team, and Eileen was part of it, had a passion for clinical care, and it was contagious, so we loved it. Our collaboration really awakened me to the power of nursing. So you can imagine my alarm when, just as the country was needing nursing to be stronger, it was weaker. The challenges we're facing are huge, they're obvious, and they're still unresolved. I want to just tell you some of the particulars that the IOM report gives us. A, if nothing changes, the U.S. will face upwards of 1 million nurse shortage by the year 2025. And that's going to be in doctors' offices and hospitals and nursing homes and home care settings. Nothing's going to be spared, every site. B, it's already happening. There are nurses, veteran nurses, who are discouraged and underpaid and who are leaving the profession. C, the oldest members of our family and our society are living longer, they're needing more care, and we don't have the nurses to take care of them. D, there's an expected surge of 32 million people who are going to have coverage in the next few years. Where are we going to get the people to care for them? D, the deepening shortage of primary care physicians is making it harder and harder for people to have a primary care doctor. And F, that all-in-one medical home that we talk so much about relies very heavily on nurses and teamwork to coordinate and manage the care, the chronic conditions, to educate patients, and to help them stay healthy. All of this is at risk. Now, the report also tells us, and it's no new knowledge to you, that there's a corollary shortage in nursing faculty that makes it very difficult to attract, retain, and train the next generation of nurses to meet the needs that we already know about, as well as the unexpected needs that we haven't begun to talk about yet. Now, compounding the shortage in nursing education is the fact that we haven't consistently kept pace with the quality standards and new technologies in all of the ways that we need to. The result is that we may be producing cadres of nurses who aren't fully prepared to take care of patients in all of the advanced technological situations that they're going to be demanded to take care of in the future. And if you add to that one other factor, that in the nursing workforce, it doesn't reflect the race, ethnicity, and gender of the patients that we take care of, and that too is an error that can lead to dangerous problems. You'll see that the problems that this report dealt with are huge and unresolved. So given all that we know, and given these decades of political and legislative sound and fury, and given that we're facing the most comprehensive change in healthcare that we've seen in more than a half a century, it is the time to look at the future of nursing and make sure that we don't squander this opportunity. Now, the Patient Protection Affordable Care Act does look at some of what you might call nursing's pre-existing conditions. The fact that we don't have an adequate workforce development, that we need investments in education, and we need investments in safety net services. But those of you who've looked at the report know that Congress hasn't appropriated funds for any of these things. But what the Affordable Care Act doesn't do is make full use of the 3 million plus nurses that need to be tapped into if we're going to achieve the full potential of this act. And I think that that's pretty amazing when you consider that the American public thinks that nurses ought to be more involved in healthcare. They think that they trust nurses more than they trust almost any other group of professionals in healthcare, more than doctors, more than pharmacists. We did a poll of opinion leaders that included business representatives, government leaders, people from academia, and they agreed that nurses should have more influence in reducing errors. They should have more influence in improving the quality of care and in improving the efficiency of care and in lowering the cost of care. What they're saying very simply is this: just as nurses are patients' primary protectors, they should also be empowered to be co-equal leaders in the healthcare system. But the fact is that these seemingly unshakable barriers to that continue. It's the custom and culture that blocks nurses from providing the full care that we know they have to offer. To me, this is a critical human and healing capital resource that we have to use fully and not squander. If we squander it, it's just plain wrong. And I think we are all here to make sure that we right that wrong. So the Future of Nursing Committee explains how to do it, and they do it with the same vision and impact of other IOM reports, ones like the Report on Public Health, or the Quality of Care, or Medical Errors. Its recommendations are complex, they're wide-ranging, and there are dozens of them, big and small, but overarching it all are 4 principal recommendations that tie the whole thing together, and that's what I want to tell you about right now. Number 1, empower nurses as leaders in healthcare. Nurses are fully capable of leading change, and the time has come in healthcare when we cannot afford not to have them lead that change and to be full decision makers at the bedside and in the executive suite. Nurses should be at the table whenever decisions are made about patient care. In turn, nurses have a responsibility, an obligation to build their knowledge and savvy and partnerships and skills to be full partners. And that is why the next recommendation is so urgently needed and so important. So number 2, align nursing education to transform healthcare and shape the future of the profession. Nursing has multiple educational pathways in the U.S., and it's unusual in that regard. The most common pathway, as most of you know, is to obtain a license in nursing is to get a diploma from a community college. That's a portal that was started in just after World War II when we had a nursing shortage. A less common and longer pathway is to get a Bachelor of Science. The fact is that no matter where we start, we need to have more nurses who end up with a baccalaureate degree, because we need more nurses who are fully qualified to practice advanced practice nursing, to be competent to deliver care in every area of the community, to provide public health, to do research, to develop the evidence that we need to develop policy and leadership going forward. Now, I know that that's a tall order, but if we begin channeling more and more students from traditional community college platforms upward to more advanced levels, we can get there. The IOM standard that they set was 80% of nurses should have a baccalaureate degree by 2020. Remember that, 80-20, that's the goal. Now, meeting this is going to require the nursing schools, like the ones that are here, to work together like they've never done before. It's going to mean it's not going to mean tearing down what's already there, but it's going to mean building opportunities to advance nurses' education that don't exist. It's going to mean that we have to have more nursing faculty, more researchers, more master's level prepared nurses, more PhDs, so that the next generation of nurses will have educators open to them, educational pathways open, welcome to them as well as themselves. Now, the report calls for an even bigger change. Listen to this. We're being asked to invent and support a new educational model that trains doctors and nurses and other health professionals together as teammates, not in a hierarchy, but together as teammates. Now, it's an understatement to say that this is going to be a big challenge for deans of schools of medicine and nursing. An understatement. A common cause like this that requires interprofessional collaboration and cross-sector collaboration is very difficult. But take heart. Now, I know from my own experiences that collaboration leads to understanding, and understanding leads to mutual respect, and mutual respect among practitioners leads to better outcomes for patients. It's not easy, It may not be an easy pill to swallow, but I can tell you, I learned the hard way that I was a better student, a better teacher, a better clinician when I was part of a team. Number 3, expand the scope of practice. Nurses are educated and prepared to deliver a higher and more effective level of patient quality care than existing state, federal, and local policies permit them to do. Now, earning a medical degree requires an enormous commitment of years of education and training, and physicians are understandably protective of their authority and autonomy and dedication to patient care. I get this. I worked incredibly hard at great expense to become Dr. Risa, MD. But I know that if doctors are not allowed to, if doctors don't expand the scope of practice, we are not going to have the quality of care that we need in this country. The hard truth is that there's an abundant supply of medical specialists, and there are not nearly enough primary care physicians and other health professionals to care for America's young families or our aging populations. The most obvious way to expand this is to deepen the professional scope of practice for the entire workforce of RNs as well as advanced practice nurses. I mean, just think about doctors' offices and the roles that nurses could play. They could play a much larger role in coordinating care and educating patients, in making sure that patients understand how to manage their chronic conditions. Think about schools and what school nurses do. They could play a larger role in ensuring that kids understand how to live healthy lives, how to prevent obesity. They can educate them about things like STDs and asthma and the chronic disease that so many of our kids have these days. To me, not advocating to support the expanding scope of practice for nurses would be to not live up to the oath that we all took that says, I'm not ashamed to say I don't know, or to call on my colleagues who have skills that can help when a patient is in need. This is the only way we're going to have access to care that our patients need and give it to them without having them leave their hometowns, leave where they live, work, learn, play, raise their families, and grow old. Now, report's only been out a week, and some professional groups we know are uncomfortable with this, and that's understandable. Because if you look at how Webster's defines scope, there are 2 definitions that are pertinent. There's one that says it limits the field, it limits the relevancy of an area. And then there's another definition of scope that says it provides space and opportunity for unhampered motion through greater thought and vision. Now, some in the status quo would like to choose the first definition. But to this physician, nursing is only going to find its future when the education and training that we provide opens the doors so that collaboration can lead to that second definition of scope. Finally, number 4. That's about workforce data. And this is the recommendation that connects 1, 2, and 3 and undergirds all of them. America's patient population is changing. We all know that. It's churning, and we have to create the information about our workforce that's going to allow us to keep pace with that. We need good, solid evidence about what works as we make these changes, and we need to accumulate and aggregate that data so that we will know what works, and we can build the capacity for a workforce that is influential and has the leadership qualities that we need for the future. How well we control and command this information will determine how well we're able to achieve our long-term goals in this decade and in decades into the future. I do know we can do this. I am certain of it. As I've said, this is the missing piece in healthcare's puzzle, and we need to complete the puzzle. That is irrefutable. It makes good sense for healthcare. It makes good medical sense. And frankly, it makes good common sense. So view this, as AFAS says, as a call to action. Do it, and do it now. What we're talking about is mobilizing a movement that is going to bring consequential change to our country in all of its essential sectors. And we take this very seriously at the Foundation. Our board views it as a legacy commitment for our philanthropy and a way to strengthen our nation, and so do I. We're prepared to stay the course, no matter how long it takes. And for our part, we've already committed $10 million to the initial effort of investigation, the research, the readying the field, and for the long period of disruptive change that is certain to come as a result of this report. Our history with change at the Foundation tells us that when you have change on this, when you're contemplating change on this scale, you need to have disparate and unexpected partners and personalities to cause that change to happen. And that's one of the reasons we've developed a collaboration with AARP. They are one of the largest and most influential member-driven consumer organizations that we have in this country. Their strength and skill in advocating for change and building coalitions is legendary. So in advance of the IOM report, we put together a relatively new center called the Center to Champion Nursing in America. And we envision that eventually this center will pull together a broad-based coalition of consumers and patients and hospitals and health systems and doctors and insurance companies, other payers, higher education, nursing schools. In other words, we want to see this center as the home base to lead this movement. I actually think the movement and the mobilization has actually started already. And the reason I say that is that last week, when the IOM released its report at the National Press Club in Washington, we had online listening outside of the Beltway, people from all across the country, leaders and educators, policymakers, people who were listening in hospitals and executive suites, from government agencies, from nursing schools. I know that some of you were among them because some of you emailed me afterwards. We know that so many people logged on to the website to download the report that it crashed. I mean, how good is that? It doesn't happen very often. And later this month, we're going to launch another website with information and resources on and two-way communications for our allies and partners like you. It's going to be called, one word, thefutureofnursing.org. We anticipate that the site's going to offer not only details on the IOM report, the recommendations, the data behind them, but also blogs so that you can post. It'll have user information. It'll have startup ideas and action steps that communities can use. It'll have examples of local programs that actually exemplify the recommendations and personal stories that illustrate exactly how these recommendations play out and the principles behind them. So remember that, thefutureofnursing, all one word, .org. Now for me, this symposium, which we're calling the Pennsylvania launch, marks the beginning of where the movement really begins. And if you'll allow me just to use a cliche phrase, I think it's just what the doctor ordered. Because leaders like you have been assembling around here in the backyard of Ben Franklin, and where he started the first hospital in this country 260 years ago, to talk about difficult problems and how we're going to address them, and how we're going to inspire one another to get things started and moving. I know that this conversation that we're about to have about the action steps is going to be a prelude to the one that we're going to have as a national summit on November 30th and December 1st in Washington, D.C. When we have that summit, we're anticipating we're going to have over 500 people participating. It'll be many of the people from the IOM committee, as well as leaders from around the country who will help us do what we need to do, which is to chart the course for implementation, the course that we're going to start talking about today. Now, I know this isn't going to be easy. As I've said, we're going to have to convert traditional adversaries into allies and working partners. And we're going to have to overcome tremendous numbers of critics and naysayers, and frankly, overcome the inertia that often leads to resistance and just keeps us stuck in the status quo. And skeptics might say this kind of cooperation is just not possible in these days of discouraging divisiveness. But I am an optimist. And when I look around and see the company that we have in this room, I have to remind you that none of us could do this alone. But we all are here because we believe that America still possesses what President Lincoln referred to as the better part of us, the angels that are the better part of our nature. So in closing, let me just tell you a story about what I mean. Back in the day when I was a primary care physician here in Philadelphia, I had the privilege of caring for a patient with ALS. She was a teacher who was determined and vibrant and was going to be independent no matter what, and no matter how bad her disease got. And I have to tell you, it got pretty bad, because at the end of her life, her muscles were atrophied. She could move one finger just a little bit, and her head hardly at all. But amazingly, she could still let people into her home, because she had a straw that she would blow on that was rigged to unlock the door and let people in. And that slight physical capability was the key to her maintaining the quality of life that she demanded and deserved. Now here's where it gets a little complicated. She was actually a patient of Jefferson Hospital. She had a home health aide that was working with an independent agency who took care of her amazingly well. Now her specialists at Jefferson took care of all of her neurological diseases and problems, but they didn't make house calls. I was a doctor here at Penn, working alongside a nurse practitioner here at Penn, and together with our geriatric team, we did make house calls. So this unlikely team of people from Jeff and Penn patched together a group of family caregivers and hospitals and primary care sites and nurses and doctors. We even had a podiatrist, all making sure that we could provide an integrated system of high-quality care that managed her chronic illness. We kept her in her home, we managed it prospectively, and it wasn't all that expensive. In fact, since she was only admitted 1 or 2 times in the entire time that we took care of her, I think it was actually downright cheap. The point is, we anticipated her disease and we met her needs, and we made it possible for her to live the way she wanted to live and to die the way she wanted to die. And all of that because of the power of a simple straw and our resolve to make the system work for our patient rather than the other way around. So I have to tell you, if that frail little old lady could open a door with her straw, then we ought to be able to open the door to the future of nursing and to a better quality health care that's safe and reliable, high quality, and fair and equitable for all Americans. Let's get started. Open the door and get the job done. Okay.
Questions now? Is it okay?
1 or 2, I
One or
guess.
2 questions now, and then there will be a lot of discussion, a dialogue, and then more questions later.
I don't know, can you hear me?
Yes.
Well, I first want to commend RWJ and the IOM for taking this brave step outside of the box. But I also am listening to you, and you're speaking to the choir here, which I know you know that.
I love the choir.
Well,
So
she's speaking to action-oriented group of people.
exactly,
from
but
different fields.
there are groups that need to hear this as well. So I'm just wondering what your plan is to spread this message to the naysayers and the people that are the groups that are going to resist.
You're going to hear a lot about that in the next panel, so why don't we revisit that after you've heard the panel, and then I'm happy to go into it in great depth. But that's a great segue into the panel.
Okay, great. Thank you. Thank you, Risa. To Risa. She's going to be around for more questions after the dialogue and the discussion. And we have the movers and shakers here. It's wonderful to have you here, Ralph Muller. One of the movers and shakers is going to put nurses at the policy table. Another mover and shaker and somebody who's really committed to nursing is our governor, Ed Rendell. He is Pennsylvania's 45th governor, and I don't think he really needs much introduction. But I just want to say, before he brings his greetings to us, that he is a governor who immediately, upon assuming the office, his first act, he signed the putting the Office of Healthcare Reform into practice, and he asked Rosemary Greco to chair that, and that was the beginning of Prescription for Pennsylvania. He launched the Prescription for Pennsylvania with the goal of making healthcare affordable, accessible, and improving the quality here. And he has so many accomplishments during his tenure as a governor, but I just want to mention 3 related to us. He enabled healthcare practitioners to practice at the full capacity of their training, which is something that this report is calling for the entire nation. He passed the toughest legislation to reduce healthcare-acquired infections, and he started the Chronic Care Initiative, a patient-centered medical home demonstration projects. And he also established the Senior Care and Service Study Commission and asked one of our faculty to chair that, Dr. Eileen Sullivan Marks, and the recommendations are going to be coming out very soon from that report. Most recently, and this is really important for all of us in nursing in this room, he has been appointed as a chair of the Advisory Council for the American Academy of Nursing Raise the Voice campaign. And he took that really seriously. A true friend of nurses, and of nursing and of quality health care. Today he's in Pittsburgh for the Governor's Conference on Women, so let's make him hear a very warm, loud of applause.
Hello to my many friends and colleagues in the wonderful world of nursing. You know of my interest in the issues important to you and my belief that nurses hold a key to solving many of our healthcare challenges that face our country today. I'd like to thank the Robert Woods Johnson Foundation and its president, Dr. Risa Lavizzo-Mourey, the Institute of Medicine, and the great Dr. Donna Shalala, the outstanding chair of the Future of Nursing Commission, for their commitment and leadership in this key initiative. Many of you know that here in Pennsylvania, our Prescription for Pennsylvania initiatives mesh with the Future of Nursing report initiatives like expanded insurance coverage for kids and adults, leadership opportunity for nurses through the Chronic Care Management, Reimbursement, and Cost Reduction Commission, the Pennsylvania Center for Health Careers, and a Health Careers Leadership Council, and especially our success in expanding the legal scope of practice for physician's assistants, advanced practice nurses, clinical nurse specialists, nurse midwives, and dental hygienists. Our goal for RX for PA was to get more value out of the healthcare system, quality care at a sustainable price. We knew that expanding practice boundaries for nurses would help us meet that goal. I created an Office of Healthcare Reform in 2003 and asked them to work with many of you to remove barriers to clinicians' practices, including permitting advanced practice nurses to offer home health hospice and other services previously requiring a physician's referral, to loosening prescriptive authority for advanced practice nurses, improving payment for primary care, and pushing managed care organizations to pay advanced practice nurses. Grants were given for nursing faculty development, recruitment, and retention. I think some of the best examples of what can happen with innovative models when nurses can practice in a way that utilizes their skills and knowledges are the retail clinics that have cropped up all throughout Pennsylvania and also the nurse-managed health centers. Pennsylvania has one of the largest numbers of these facilities in the country, and we're very proud of that. There's still more to do, and I hope with the foundation we've laid that the reforms continue long after my term ends in January. I've had a wonderful partnership with nursing leaders across the state, in particular the great Dean Afaf Malise. I look forward to continuing these relationships in my role as chair of the American Academy of Nursing Advisory Board. So thanks to all of you for all you do. I believe with all my heart that nursing holds the key to accessible and affordable health care for this country.
Good afternoon, everybody. Thanks. I'm Julie Fairman. I'm a professor here at the School of Nursing and a director of the Barbara Bates Center for the Study of the History of Nursing. Last year, I spent the year at the Institute of Medicine as the American Nurses Association, American Nurses Foundation, the American Academy of Nursing, Distinguished Scholar in Residence at the Institute of Medicine. And this could not have come at a more opportune time. For this fellowship, which is such a wonderful opportunity, I had to do a project. And what better project to do for a nurse at the IOM at this time period is to work with the committee on the study on the future of nursing. So for the last year, I commuted back and forth from Philadelphia to Washington, working with the committee. I'd like to introduce, actually, somebody who is here who was the project director for that study, Sue Hassmiller from the Robert W. J. Foundation. Did a yeoman's job in terms of, and you want to hear the inside story, did a yeoman's job in terms of keeping us all on message, keeping the staff together on message, putting forward an organized and wonderful, wonderful committee to get this report out. The inside story on this is that this was an incredibly productive committee. People from all over, all different professions and disciplines came together to think about the future of nursing. We had people who were experienced economists like Bob Reischauer, and we also had junior faculty members like Rosa Gorda Dawson, who is an assistant professor at the University of Miami. All of these people came together to develop this report and the recommendations that some of you may or may not have read. Now, the rest of this program will consist of a couple of components. I will talk to you and walk you through the recommendations and talk to you a little bit about the evidence of these 8 recommendations. We then will have a panel discussion with Dr. Julie Sochalski and Dr. George Thibault. And I will introduce them after I'm finished walking you through the recommendations. We will then have them speak both to the federal perspective and also to the foundation perspective. And then we will have a lot of time for questions. I do think that there are a lot of questions out there. I think that there are a lot of fears, and there's also a lot of joy in terms of what this committee has recommended. So let me just start out by saying that there are 3 million nurses in this country. Not only does it constitute the largest group of women workers in the country, it is also the largest group of workers in the country. From California, we know that 1 out of every 8 workers is a nurse. It is a large body of people, and we should have, and we do have, a lot of power. We have a wonderful opportunity here with the Affordable Care Act. Nurses are poised to bridge the gap between coverage and access and to coordinate increasingly complex care for a wide range of patients. To do this, they must be able to practice to the fullest extent of their knowledge and skills across all levels of care and all levels of nurses. And their economic value must be realized. Now, the report did point out some challenges. And one of them was that the profession is not as diverse as it should be, nor is it equipped as well as it should be to deal with a broad scale of diverse populations. But through the report is threaded recommendations for how to improve the diversity of the profession. We know that many members of the profession need more education to fulfill the potential within a reformed healthcare system, in community health, in public health, as case managers, and as members and leaders of teams. We know that we don't have enough expertise in geriatrics, palliative care, public health, and community and mental health nursing. That is one of our challenges. Those are many of our challenges. Now, the recommendations are based on evidence. The way this process works is the committee develops the report. It then goes to a group of outside reviewers who read it with a fine-tooth comb and come back with queries. All of those queries must be addressed. All the evidence has to be there. The facts are checked. This is an IOM report. It is one of the most well-known and well-regarded sources in the world. So anything the Institute of Medicine puts out, you know, has gone through a process where the evidence and the facts have been checked. Now, there are 4 key messages in this report. First of all, nurses should practice to the full extent of their education and training. They need higher levels of education. They need to be full partners with physicians and other health professionals in redesigning healthcare in the United States. And fourth, effective workforce planning and policy requires better data sets. When we're trying to pull together all the evidence for the commission in order to make their recommendations, we found ranges of data and ranges of findings. So the question is, how do you know what to believe and what to understand? So the last recommendation in particular, recommendation number 8, has to do with better data collection methods, and I'll talk about that a little bit later. I love this map. This is from ARP. What this shows is that nurse practitioners, advanced practice nurses, can practice independently in 14 states in this country, plus the District of Columbia. In the rest of the states, including Pennsylvania, there are separate and different requirements in terms of physician supervision of prescription, nurse practitioner, advanced practice nurse-physician ratio, the idea of on-site versus direct versus off-site supervision. None of these state practice acts, all 50 of them, are different, as you know. None of them are based on evidence, which brings me to the first recommendation, to remove the scope of practice barriers. Now, in these recommendations, we have identified actors for each component of these recommendations. There are 4 for the Congress alone. The Congress needs to expand the Medicare program to include coverage of advanced practice registered nurses within the scope of their practice, just as physician services are now covered. Federal programs pay for a majority of the health care that's given in this country if we include Medicare, Medicaid, the Veterans Administration, and the Bureau of Indian Health Affairs. Second, the Congress should amend the Medicare program to authorize advanced practice nurses to perform admission assessments, as well as to certify patients for home health care services and admission for hospices and skilled nursing care. They should extend the increase in Medicaid reimbursement premium that they did for physicians. I believe it's a 10% for primary care. They should extend that to advanced practice nurses. They should also limit federal funding for nursing education programs. In states, limit federal funding for nursing education programs to states that have adopted the National Council of State Boards of Nursing Model Practice Act for advanced practice nursing. And I'm going to read you what that act says. Advanced practice nurses should practice as licensed independent practitioners within standards established and or recognized by each state board. Each APRN is accountable to patients, the nursing profession, and the board for complying with requirements of this act, including quality care, for recognizing limits of knowledge and experience, planning for the management of situations beyond their expertise, and for consulting with or referring patients to other healthcare providers as appropriate. This is the statement from the National Council of State Boards of Nursing that we recommend all states should adapt. For state legislatures, reform scope of practice regulations to conform to this National Council of State Board of Nursing Practice Act, and require third-party payers that participate in fee-for-service payment arrangements to provide direct reimbursement to advanced practice nurses who are practicing within their scope of practice in the state. For the Center for Medicaid and Medicare, amend or clarify the requirements for hospital participation in the Medicare program to ensure that advanced practice nurses are eligible for clinical privileges, admitting privileges, and memberships on medical staffs. For the Office of Personnel Management, require insurers participating in the Federal Employees Health Benefits Program, one of the largest insurance programs in the country, to include coverage of these services of advanced practice nurses. We also call upon the Federal Trade Commission to review existing and proposed state regulations to identify those that have anti-competitive effects without contributing to the health and the safety of the public. The FTC has a long history of doing these kinds of things, and in 2008 alone, they evaluated proposed laws in Massachusetts, Illinois, and Kentucky, finding that several provisions of these state acts could be considered anti-competitive, including limits on advertising, differential cost sharing, more stringent physician supervision requirements, restriction on clinic locations and physical configurations or proximity to other commercial ventures, and limits on the scope of professional services that can be provided that are not applicable to professionals with similar credentials. And this includes urgent care centers. The other thing I should note is that this scope of practice recommendation does not only apply to advanced practice nurses, it applies to nurses across all levels. And this may include both technical and critical thinking functions. So think about this as broadening the scope of nurses at all levels. The second recommendation looks at expanded efforts for nurses to lead collaborative improvement efforts. For example, nurses should expand the private and public funders, healthcare organizations, nursing education programs. You can see we're getting everybody involved in here. This is not just for nurses to take forward. This is for everyone to be involved, to come together to figure out how we can best improve patient care. To this end, the Center for Medicare and Medicaid Innovation should support the development and evaluation of models of payment and care delivery that use nurses in expanded and leadership capacity. I refer you all to the transitional care model that Dr. Mary Naylor has implemented here and is being implemented across the country. Private and public funders should collaborate when possible to pool funds and advance research on models of care and innovative solutions, including technology that will enable nurses to give better patient care. These models could include the retail clinics that the governor spoke to. It could also include nurse-managed health centers. For example, when the committee came to Philadelphia in one of its public forums, they went to a number of nurse-managed health centers so that we could show the committee members what the potential was. We went to Life. We went to the Drexel 11th Street Family Health and Counseling Network. We went to many different places where nurses are taking the lead and provided high-quality, easily access patient care. Healthcare organizations should support and help nurses in taking the lead in developing and adopting innovations in patient-centered care models. We already see that in our state, the Geisinger Health System, where nurses had ideas, they made changes, they improved patient care. We see this in the VA system and at Kaiser Permanente. There are many examples of things that are going on in this country that can help move the agenda for health forward. As one person said in one of our public forums, the future is here, it's just not everywhere. We also want healthcare organizations to engage nurses and other frontline workers, staff to work with developers and manufacturers in the design, implementation, and evaluation of medical technology. Nurses should be the ones, in collaboration with other professionals, who decide how things work and how they work best. They should also be pairing with engineers, with other kinds of professionals to develop new devices that work better for patients. Within our school here, we have Dr. Barbara Medoff-Cooper, who's developed a very innovative device that is in the nipple of a baby bottle. It's a little computer chip. It evaluates the sucking capabilities of preterm infants and helps to decide whether or not they're ready to go home. Will they survive? Will they feed? It's innovations like that that nurses are doing across the country. And there needs to be more and more support for them to do this and support for that to go forward. Nursing education programs should provide entrepreneurial professional development that will enable nurses to initiate programs and businesses. Nurses are incredibly entrepreneurial. They have their own practices. They work with physicians in collaborative practices. They should be able to use the knowledge and skills that they gain in their programs to change the system, to move these models forward. The third recommendation is to implement nurse residency programs. Since 2002, the Joint Commission has recommended the development of nurse residency programs, as did the 1983 Institute of Medicine Commission on Nursing and the 2009 Carnegie study by Benner and her colleagues. We've been talking about this for a very long time. We have evidence that this works, that successful models exist. Staff turnover within the first year working in acute care settings and actually across the healthcare system is very, very high. It's very hard and it's very expensive to employ a nurse, train them, orient them, and have them leave within the first year of their practice. For example, there is one hospital in California that has a program. It costs $93,000, but to replace a new nurse costs $45,000. So one program for just one nurse will cut the cost curve there. In non-acute settings, the New York Visiting Nurse Association has a residency program for nurses and for nurse practitioners. The Accountable Care Act has allocated $200 million from 2012 to 2015 for demonstration projects to train, to pay hospitals for the costs of clinical training and to prepare APRNs with skills necessary to provide chronic care, primary care, and care management. The opportunity is out there to be creative and to be innovative. With this recommendation on residency programs, there is also provision in there for the evaluation of these programs. For states' boards of nursing to support nurses' completion, all kinds of agents and actors to come together to put these kinds of programs in place in order to keep our young nurses in the profession and to make them more productive. The committee also recommended that the Secretary of Health and Human Services should redirect all graduate medical education funding from diploma programs to support the implementation of these nurse residency programs. This is one way that the funding of these programs can be taken off the ground. In 2006, about half of the Medicare funding for nursing education went to 5 states. There has to be some better allocation of funds for this. Recommendation number 4 looks at increasing the proportion of nurses with a baccalaureate degree, 80% by 2020, 80-20. Now, there are many ways that this can happen, and we've seen these models all across the country. We've seen online programs, the Western Governors Program. We've seen community colleges pairing with other academic institutions and universities. The OCNI model, the Oregon Nursing Consortium, the Oregon Consortium for Nursing Education. It's a program that's brought together about 17 community colleges in Oregon with the University of Oregon. What they've done is develop an innovative curricular structure. Well, for the first 2 years, at least, the nurses, the students in the AD programs, and the students in the baccalaureate programs share a curriculum. They've gotten buy-in from the community colleges and from the universities. About 20% of associate degree nurses go on for further education. In this Oregon model, 40% of the associate degree nurses go on for a baccalaureate degree. There are currently 8 programs that are beginning to develop this model, and there are 10 more models in development coming on. University of Hawaii probably is the furthest along. Same issues in Hawaii as we have here in Pennsylvania in terms of great distances between education institutions and students across all of the islands. Recommendation number 5. Am I 5? Okay. Is to double the number of nurses with a doctorate by 2020. We are in desperate need of more faculty within the nursing profession. And the only way to do that is to move people faster through the pipeline, either from associate degree or baccalaureate programs through master's to the doctoral level. The Commission on Collegiate Nursing Education and the National League for Nursing should monitor the progress, this is one of the considerations, of each accredited school of nursing to ensure that at least 10% of all their baccalaureate graduates matriculate into either a master's or a doctoral program within 5 years of graduation. There's a very, very small proportion of doctorally prepared nurses in this country. To say 10% is saying a lot, but I think we can do it. We can think of innovative strategies, either from AD to PhD, the BSN to PhD, all kinds of innovative programs to move this forward. The other thing that the committee looked at was the potential of second degree students. And they call on various government agencies to increase funding for students of this type to move them faster through the pipeline. They also call on academic administrators and university trustees to create salary and benefit packages. One of the reasons for the shortage of nursing faculty is not only because we are getting old, and believe me, we are, but there's a big salary differential between master's prepared clinicians who work in acute care institutions and those who work in universities in clinical practice. There's a call for these academic administrators and trustees to create salary and benefit packages that are market competitive to recruit and retain highly qualified academic and clinical nurse faculty. We have to make this an attractive thing for them to do, to come into academic institutions, to give these students the knowledge, the clinical knowledge that they have. Recommendation number 6 is to ensure that nurses engage in lifelong learning. So they're asking for faculty to partner with healthcare organizations and to develop and prioritize competencies so the curricula can be updated regularly, that all nursing students can develop and demonstrate a comprehensive set of clinical performance competencies. Many of the organizations already have established competencies. This is not something that has to be reinvented, but it's something that has to be flexible, that it can actually represent the changes that are going on in the ground in healthcare. Academic administrators should require all faculty to participate in continuing professional development and to perform with cutting-edge competencies in practice, teaching, and research. All healthcare organizations should foster a culture of lifelong learning and provide resources for this. Recommendation number 7, prepare and enable nurses to lead change to advance health. I think leadership is one of the most important things that this report puts forward, nurses as leaders. Nurses are great team members too, but they're also great leaders. And they should fluidly move between these roles within the healthcare system. The committee believed nurses should take responsibility for their personal and professional growth. So we're not only saying that other people have to open up opportunities for leadership for nurses, The committee is saying that individual nurses need to take the leadership for their own professional development and their own leadership opportunities. I was just at a conference last week talking about nurse practitioners in scope of practice. And one of the participants in the conference stood up and said, well, nurses have this shift work mentality. They don't like to take responsibility beyond their shift. They only will work their 8 hours. Where is that coming from? Where's that coming from? There must be something going on in terms of nurses taking responsibility for their own actions and developing their own leadership capability and capacity and moving things forward. Nursing associations should provide leadership development and mentoring, and we already see that happening. And SEMA has a wonderful, wonderful mentorship program, as does the National League for Nursing and the American Association for Colleges of Nursing. There has to be opportunities for nurses to take advantage of these programs. Nursing education programs should integrate leadership, theory, and business practices across the curriculum. Many programs already do that, but many, many do not. And the main thing, public, private, and governmental healthcare decision makers at every level should include representation from nursing on boards, on executive management teams, and other key leadership positions. Who is better qualified to be represented on a board for safety and quality issues than nurses? This is a call. This is a call for everybody to participate and to help move these recommendations forward. It's a great time to do this. Things are changing. I think I heard 28 states are already beginning to open up their practice acts. This is the time, and we all have to take charge, and we all have to play a part to move these recommendations forward. Thank you. Now, I'd like to invite the two panelists to come forward, and I'll introduce them both first, and then they can proceed. Our first speaker will be Dr. Julie Sochalski, who is a nationally and internationally recognized authority in health policy and the healthcare workforce. And as you heard from our Dean from the Lease, is the new Director for the Division of Nursing at the Bureau of Health Professions, the U.S. Public Health Service. And I must also say that Julie remains, you're still a member of our center, the Barbara Bates Center for the Study of the History of Nursing, and we're very proud of her. Our second speaker will be Dr. George Thibault, who is the president of the Macy Foundation. And immediately prior to that, he has done a lot of different things. And he has, as we had lunch with him today, decided that his chief interest right now is for interprofessional education. He's really excited about that. The foundation has several programs that promote that, and he will be talking about the foundation's role in implementing these recommendations. So we'll start first with Dr. Sochalski.
I'm going to assume that you can hear. This is on? Okay. So FF, I think you're right. Not only was every seat filled, but I've now watched them like turn over. So I think the second shift is there, so I think it's more than filled. It's a real pleasure to be back. See so many faces, I remember. To be back here. What a time for nursing. I mean, I have been in the position as the director of the Division of Nursing for just over 5 weeks, and as I describe it to people, I found the coffee shop and the bathroom in that order. And so I apologize if I'm looking down. It's like these numbers that would probably be very familiar to me. And sometime I'm still learning as I'm going along. But I think the central message, and I don't want to take a lot of time, you've all been very patient, I'm sure you have a lot of questions, and the dialogue will be a lot more interesting than listening to us. But I think it was capped off perfectly by what the charge that you got from Risa and from the report. And that is, this could be another report with great things in it and sits there. And so now's the time to act on those. And the report, as Julie has shown you, has identified a number of different actors and organizations that can play a role. But the role is really going to be played by each one of you and each one of us. George and I were talking before this, and I said, you know, I think that there's the challenge that we face, I think, can be well faced by the clinicians that are delivering this care. That our commitment is not only to this report, but to bettering the health of the public. And if the nurses who've got great street cred and doctors who have great street cred and all of the people that are engaged in the delivery of healthcare services took it upon themselves to say, we're going to do it better. We're going to seize these, because the report, when you look at it, talks so much about the incredible importance of bringing together all members of the team. It specifically looks at advanced practice nurses, but also looks at direct care workers and says, if they are an incredible, important part, if you count up all the registered nurses, all the licensed nurses, and those whom they supervise, the nursing assistants and others, that nursing personnel body is roughly 50% of the entire healthcare workforce. It's a lot of people that are delivering a lot of services, and there's a great opportunity for us to work together. Now, real time, while all of you were busy in the committee, what was going on at the exact same time was two very important things in the federal government. That was the, and I've got to tell you, the pleasure of being back out of Washington and to be able to speak English words. I don't have to say everything as an acronym. And I was saying to George, not only acronyms, but they're acronyms that have no vowels, and you have to learn how to pronounce them. So we don't even call it the Affordable Care Act. Oh, you look, yeah, you don't know what you're talking about. And you can't even call it ACA. You have to call it ACA. So I'm going to call it Affordable Care Act and relish the opportunity to say those things. Oh, yeah, we can't call it the Recovery Act. It's ARA. So I'm going to ignore those for the moment. So real time, while you're assembling and doing your work, the Recovery Act was passed and the Affordable Care Act was passed. And within both of those came great funding opportunities and new authorities that parallel so closely what is being discussed here. And so we do have, there was over $11 billion that were put into community health centers. So going forward, you're looking at, we're going to cover 30 whatever million new people. You also have an economy in which many people have now found themselves without health insurance and are looking at where is affordable access as we're waiting for health reform to be passed. Well, we had an enormous investment that was put into community health centers. There has been investments over $300 million that was put in for health professions training with a specific focus on primary care. We saw boosted up funding for that, not just primary care residencies. We're looking at physician assistants, advanced practice nurses. With those investments, we're looking at over 2,000 additional providers of services out there just coming out of these two funding sources. What Risa pointed out is important. There is additional authorizations for more training. I just do what the Congress gives me the money to do. So if those are not appropriated, those won't be fulfilled. But there are additional authorities that are in there. There was over $1 billion put into the National Health Service Corps. Additional funds that were put in order to provide loan relief for people that do choose the health professions. That's an enormous investment over what's been put in over the last few years. That has over 15% of the people that are currently in the Corps, which is numbers at around 4,800, over 15% of those are advanced practice nurses. When you look at community health centers alone, it's impossible to think that they could do their job if they didn't have a strong, robust group of registered nurses. That's not just advanced practice. 15,000 registered nurses working in our community health centers, a third of which are in advanced practice, all of which are getting boosted up funding. You look at the shortage of nursing and the need that we have for faculty, what we've seen over the last 2 years with the Recovery Act, funding from the Recovery Act and the Affordable Care Act, we've nearly doubled, actually more than doubled, the investment in nurse faculty programs. We also see through the traineeship programs, the advanced education nursing traineeship programs, an important thing to the goal of trying to increase the number of doctorally prepared faculty, there had been a cap on the amount of money that could be spent on doctoral education. That's been lifted. So the Affordable Care Act has lifted that and allows us to now fund at all levels of graduate education without limiting that field. That'll go importantly towards that. We've also, from our normal appropriation as well as from the Affordable Care Act, we've increased the number of nurse-managed health centers. 10 new nurse-managed health centers were funded, and that's on top of over 20 that we've already been supported. Those are important because they deliver essential services. They are important training centers. And you look at interprofessional education, you have the opportunity to provide primary care education to advanced practice nurses, to nurses, as well as all providers. Can we teach this team model in these places? So additional funds going there as well. There was also money made available through the Recovery Act to provide faculty with funds for training equipment. We just sent out, it's interesting, you know, these letters that I signed for these awards, I'm thinking, I hope somebody's got these numbers right. A lot of money moving out there. But we funded, there was over $50 million that was made available for pedagogical technology, new training. We're actually, within the Division of Nursing, are now looking at, we have consortium that faculty that have been funded to help develop, and we have people over here that are getting equipment, like, hey, why don't we get the two of them to talk to one another so that we can expand and use those dollars most effectively. So there's been a number of investments that have been made around the very things that are a part of the report. So while that was going on, it's almost like we were a little bird in the room and, you know, taking these things back and doing them. But it does say that there's a real partnership here between where the federal government is looking with the funds that they do have. And I'm just talking about the administrative side. The Congress, those are the kids downtown. We're up, you know, we work with the appropriation that we do have. But the partnership is there. But we're only one of those lines that were in those slides. If we don't all come together, and I really do think that it does start with the clinicians that are on the ground. That is, every single one that is out there delivering these services, not only delivering them to the best of their ability, but also coming together to make some of those changes. Oh, that's right. If you didn't have pushback on a report, you probably didn't say anything that really needed to be done. So you are going to hear some. You're also going to hear tremendous support. I think the public knows what it is that they don't have and what they could have. And I think with the partnership we have here and with the report, we each have an obligation to take it and make it so. And I'll turn it over to George.
Well, what a great occasion. I want to thank Afaf for the honor of being asked to be here. And what a great audience. You were so patient. I'm putting away my prepared remarks. You've heard too much already. I'm going to make a few personal comments. So the controversy has begun. This is modern healthcare. I call it the Sports Illustrated of healthcare administrators. And this arrived on my desk yesterday. The Institute of Medicine backs expanding advanced practice nursing. Headline says, Doctor Nurse. And underneath it says, critics contend change will undermine physician supervision of healthcare and harm patients.
undermine.
So
Like that.
it's not going to be easy. But I know a little bit about controversy. Earlier this year, our foundation sponsored this conference called Who Will Provide Primary Care and How Will They Be Trained? And intentionally, it was co-chaired by a nurse leader, Linda Cronenwett from UNC, and a physician leader, Victor Zhao from Duke. And one of the recommendations, among many, said the following, and it will sound familiar to you. State and national legal, regulatory, and reimbursement policy should be changed to remove barriers that make it difficult for nurse practitioners and physicians' assistants to serve as primary care providers and leaders of patient-centered medical homes or other models of primary care delivery. All primary care providers should be held accountable for the quality and efficiency of care. This was one of many recommendations about the context in which primary care is provided, about the educational interventions necessary to make it a more attractive career, and about generating leadership in primary care in the future. But this one got the most attention, and I was subject to a fair amount of attack from my physician colleagues in a number of organizations. So I know a bit about controversy, but we're headed down this road, and there is no question it's the right road to go down. So I want to make a couple of comments about each of the four messages that Risa spoke to. And each of them resonate with things that we are working on as a foundation and that we strongly support. First, about the expanded scope of practice. There is strong evidence cited in the report that appropriately trained nurses can and do provide high quality, efficient, patient-satisfied care. And this is not just a moral imperative, it's a pragmatic imperative. We are not meeting the healthcare needs of our public now, and we certainly will not be meeting the healthcare needs of the public when 30 million more people have the promise of having access to that care. This is not a doctor versus nurse issue. This is the public good issue. But I will say three caveats about that particular message that are important for us to remember. First of all, I would broaden it to say that all health professionals should practice up to the full scope of their education and training. This is not just a nurse issue. We need more data and information about what are the appropriate roles and jobs for everybody in a well-functioning healthcare team, including the physicians. What is it that the physicians can and should do that their added training enables them to do? We haven't defined that well enough. And I think that this discussion should be much broader than just framed as a nursing scope of practice discussion. Secondly, even if we are to remove all of those barriers, which I hope we will, and the movement is slow, but it's moving in that direction, we will not have enough primary care providers by any stretch of the imagination. Right. So it is incumbent upon us to continue to look at models of care that will enable us to provide that primary care, and for all the professions to examine themselves, what is it about the recruitment process and the training process that would make it more attractive for people to pursue those careers. And we know something about that. Some of those issues are addressed in this report. And we know particularly that educating and training people in settings that exemplify the kind of collaborative, patient-centered care that we want to produce is more likely to produce people who choose that as a career and function well in that. We cannot continue to educate and train in dysfunctional systems and then wonder why people don't choose to do that or don't function well if they do choose to do it. The third caveat about the scope of practice is that the principles that it speaks to are not just primary care principles. And while primary care is very much on our mind because of the promise and the imperative of the Affordable Care Act, the principles of collaborative care, of everybody functioning up to their highest level, apply to all parts of a well-functioning healthcare system, not just primary care. So that's message number one. Message number two is about transforming the education system of nursing. Now, it has already been acknowledged and it's well documented in the report that there are very specific challenges in the nurse's educational trajectory that are different than other aspects of the health profession, and that there are these multiple paths to licensure. And there is evidence, again cited in the report, that this, in fact, has had a negative effect on quality of care, and probably will have even more as that care becomes more complex. I would posit it's also had a negative effect on our goal of teamwork in interprofessional relations, because it's made very ambiguous how you create those matches when you have such inequality. So both of those goals, better care and better interprofessional relationships, will be served by this goal of making that pathway more uniform and uniformly rigorous. I must say, of all of the messages and recommendations, though, it's the one I find most daunting, to think how that goal will be accomplished while still making use of all that nursing workforce that we need to make use of, and expanding it at the same time, and making this transformation at the same time, is, I think, perhaps the most daunting of the tasks laid out, but it's very important to be done. But the caveat I will give there, to put it in context, is that we believe that it's not just nursing education that needs to be transformed, but it's all of health professions education that needs to be transformed. We are not now meeting the needs of the public across the board. And there are many aspects of our educational model that needs to change, and first and foremost is that we must be educating and training our health professionals together. It makes no sense to be preparing people for a life in which they're going to be working in a team with other health professionals, but isolating them for 4, 6, 8, 10 years into separate silos. So a transformed healthcare educational system will be interprofessional. It will also include new content areas like patient safety, quality improvement, systems analysis, an understanding of health economics, an understanding of the social determinants of disease. It will have different models of clinical education that will be more community-based and more longitudinal, more real world. It will also incorporate more science and technology into clinical care, not separate it from clinical care. And it will also have a model of continuing education, which is also collaborative, interprofessional, and more related to practice improvement. Now, every one of those changes nurses can lead in, but every one of those changes is needed in all of the health professions education, and they should be and can be done together. So this is not just a challenge to nurses alone. Get out there and fix your educational system. We need to do that together. The third message has to do with leadership, nurses as leaders. And I would say if we accomplish the first two goals, that is, if we're all practicing up to our full capacity and we're educating together and training together, there will follow as the night the day that we will be leaders together and we will transform together. But that's a generational change. And in the meantime, there are things that can be done and should be done to involve nurses in leadership training programs that are interprofessional, not just nursing, but interprofessional, again, modeling the real world that they're going to be leaders in. To support more combined degree nursing programs, RN MBA, which I know exists here, RN MPH, RN MPP, to prepare nurses for leadership positions. The fourth message has to do with a call for more data, and of course no academic report would be respectable without a call for more data and more research, but in fact it is needed, and we've called for it too. Our workforce data are totally inadequate. They're inadequate in both the quantity and timeliness of the data, but they're also inadequate in the quality of the data. The data are fragmented and, quite frankly, would say, and every profession has been guilty of this, they're used in self-serving ways to make the cause for a particular profession or a particular issue rather than looking at it from the standpoint of the public good. So in the Affordable Care Act, an analytical workforce capacity has been created in HRSA, and an impartial workforce commission has just been appointed, though not funded yet. We need to support these activities. We need to put aside our professional, regional, and institutional interests and support a real truth-seeking role of what should the workforce look like. Not what do we want it to look like as a doctor or as a nurse, but what should it look like to serve the public interest, and really seek the data and explore the models that will enable us to do that planning. I can say, and it was alluded to before, some of the most exciting work that we've been involved in as a foundation over the last 2 years has been the work of getting the professions together around education. We are now working at about 16 pairs of medical schools and nursing schools across the country. And people said this couldn't be done, where we actually have leaders, including the deans in many instances, of medical schools and nursing schools getting together and planning curriculum together. Planning in an intentional way those educational experiences that should be shared and then reinforcing them. It's only the beginning. It's not yet the norm, but I envision the day in which it would be as abnormal to go through a health profession education system and not be educated with other health professionals as it would be not to take physiology or biochemistry. It would be so strange. How could you do it that way? So this is a very great moment, not just for nursing, but for all the health professions and for the public. And I believe we owe a great debt of gratitude to the commissioners who put this report together, to the IOM, which gave its rigor to it, which gives it credibility and visibility, and to the wisdom of the Robert Wood Johnson Foundation for funding this, driving this, and continuing to stay with it, and we will be with you. And I look forward to this. This is an agenda for a decade or more. It's going to be hard work. We know not everybody agrees, but history is on our side. Thank you very much.
Thank you for those very wonderful comments. It sort of brings everything together that we've been saying today in terms of individual responsibility, moving this forward, gaining the momentum. So we now have time for questions. And we do have a few questions.
Risa? Risa, you should come up.
Yeah.
Yeah, Risa, yes, please, come up. We have two students who are in the audience with microphones, so we'll start with Anne.
Ann O'Sullivan, professor of nursing here at the School of Nursing. I practice as a pediatric nurse practitioner across the street at the Children's Hospital of Philadelphia. I had the honor of chairing the National Council of State Boards APRN committee that developed those model rules and regs for APRNs. But I'm here today with my hat as the chair of the State Board of Nursing and my colleague, vice chair of the State Board of Nursing, Joe Napolitano, down there in the second row, to announce that in the spirit of the Pennsylvania launch, the Pennsylvania Board of Nursing this morning released at the FENSA meeting a letter to all schools of nursing, program directors for the graduate programs that prepare APRNs, alerting them that Pennsylvania, too, is getting ready to implement many aspects of the consensus model that are matched with the APRN model rules and regulations, so that we want all of the schools of nursing to start getting ready to change their curriculums so that our students will all be prepared to take the new national certification exams, which will be available as of 2013, in an effort that by 2015 we'll all be able to have implemented many of the aspects, if not all of the aspects, that are in the consensus model that is then patterned in the APRN model rules and regs that are mentioned both in the IOM and then listed in the IOM. Thank you very much.
Thank you, Anne. Down here, Dr. Rubenstein.
I just want to, I'd like to, of course, compliment the IOM and its leadership on this really, I think, stellar report. And of course, listening to Risa, I don't know how anyone could even think of not supporting it. So, Risa, that was the most eloquent, wonderful talk I've heard for a very long time. And that's not to say the rest of you weren't pretty good too, but
That's okay.
I think not quite as good as her. So, so I think not to just repeat what's obvious. You know, there have been multiple reports by the AAMC, the AHC, the Macy Foundation, and on primary care, probably 20 others. And I would say they've had rather minimal effect. In fact, everyone has said there's a shortage of healthcare professionals. There have been multiple recommendations about what to do about them, and I've watched with interest how nothing has happened. So I think the really important issue is what many of you commented on, and that is this a special time, a tipping time, because of the Affordable Care Act, because of the public disaffection with the healthcare system and because of the quality of this report, that something can happen that will change the way that not just nurses, but as my good friend Dr. Thibault has said, all of the healthcare personnel will come together to deliver care in a more creative and team-approached way. Now, I think, honestly, that because of the money that's in the Affordable Care Act and the pressure behind doing something useful with it, that this is a unique time. And I just want to say that from my point of view, what George says is true. Although it was hinted at many times here, that we have to find physician champions who join with you to do this. Because to do it around the medical profession just won't work. To do it with some of the established organizations may not work either, but there are others around that I think will buy into this and be your partners. And we got to include others like osteopathic physicians and others that, you know, MDs have tiptoed around, just as they have maybe with nurse commitment to patients, where we have to work together to find the way to deliver care for our patients in a much more proactive way. Now, I do want to say that my colleague here, Mr. Ralph Muller, has led such initiatives in our own healthcare system, and I would ask him to say some of the things that we've done, which is not to say we don't have a long way to go, but I would say that University of Pennsylvania, Penn Medicine, right behind UFUF, because if we weren't behind her, she'd kind of kill us, and that's a very bad situation to be in. So being very self-protective of my my being, I want to say, UFUF, we right behind you and the nurses, not in front but behind. And I'd just like to ask Ralph now to just in a short say some of the practical things that can be done right up front that we hope can be generalized around the country.
And I just want to make one comment. I mean, you mentioned a tipping point. And one of the things that you do take away from this report is, or if in the title is the future of nursing, and that's where they started, what you hear is that that's a lens in looking at the entire healthcare system, all the pieces that do have to change. And this may be the tipping point for saying it isn't any longer the silo of the primary care docs, the direct care workers, or the nurses. If we're thinking about this in teams, how do we do it? How do we face that challenge? And where do we look for the champions among ourselves, which may not be the organizations?
Well, I'll just speak briefly now. I want to echo what Arthur just said in terms of just superb comments today. And what we've done is it repeats many of the themes we've heard from all of you today, which is at the front line, put the doctor and nurse together to solve real issues of patient care, improving quality along the lines that the IOM has indicated for 10 years since to urge human the quality chasm, to work on the core measures that CMS and the Joint Commission, many others push as well, to focus on real outcomes, not just on process measures, and to solve real problems every day. And so we have this leadership model where every patient unit of our health system now has a nurse leader and a physician leader as joint leaders in running it, and they're there every day, and they deal with the issues of patient care every day. So I believe, as Julie and Julie, all of you have said today, it starts from the frontline practice of care. And when you solve real problems on a daily basis, then the world really changes. I would echo what Arthur said as well, that it is of critical importance that the nurses get others, not just other caregivers, to get involved in this as well. You know, many times, I know it's been your experience and our experience as well, where nurses feel very confident speaking about nursing and feel not as confident about speaking other parts of practice. And I think one has to kind of, as Nixon went to China, the nurses have to go beyond their own nursing profession to really change this. And I think the kind of leadership that this the IOM and the RWJ has done here gives you the principles and so forth. But I think it's just critical now to move. And I whether it's a tipping point or not, who knows? But certainly, with 32 million people coming into insurance 3-4 years from now, when we see the Massachusetts experience, as George and others said, there's an enormous gap out there right now. That's a crisis that the public is going to face in major ways. So really revising the care system at the front level is going to be an opportunity. And I think it will be met, because the American population just can't survive without this kind of reconsideration. But I commend you for pushing it, Risa and the IRM and George and all the rest of you, because this is so appropriate. And I think having the school here be at the center of all this, and certainly we feel in the health system, without our partners in the nursing school and the thousands of nurses you produce for us every several years, that really have made this a great center for the country is really something we rely and depend upon. And I think putting more and more nurses into leadership position, as we have at the health system, is exactly the way to go to revise care.
Thank you, Ralph. Victoria Rich has a few comments also.
Is it on? Good afternoon. I'm Victoria Rich. I'm the chief nurse exec at the hospital system here, and I'm also proud to be an associate professor on the faculty. And one of the hallmarks of why we are so great at Penn Nursing is because Dr. Melissa and I have a really strong partnership. And what we do is we really look at how we educate the nurses, and then I see it fulfilled in the great magnet organization that we have here at Penn. And so, when we go down through all these IOM points, I'm very proud, not only what Ralph has said about the unit-based clinical leadership, where we have the doctor and the nurse leading those units and looking at our transitions in care, but also at the University of Pennsylvania Health System, we only hire baccalaureate nurses, and right now at HUP I am over 92% of baccalaureate nurses, and I'll tell everyone in this audience it makes a keen difference, and it really is the future, and we are very proud to say that we are for this, and we are leading the way here at Penn. And thanks to Dr. Melise and to our great speakers. Thank you very much.
Hi, I'm Rebecca Bryan, nurse practitioner, and I'm on the faculty of the Family Nurse Practitioner program here, and master's prepared, so I look forward to increased support for teaching. But what I wanted to comment on was that I think part of the problem with the turf wars that we see going on is that the scope of practice for physicians is so expansive and all-encompassing that they act as if those are the strict boundaries and nobody can enter, when the truth is there's a great deal of overlap. And I just hope that that message is going to come through, that they don't have to feel threatened. They can still do what they want to do, and we can do it too.
Would the panel like to comment on that?
Well, you probably are best to comment since you had direct involvement in writing the recommendations, but in my reading of them, that point comes across quite clearly. And I just hope that as we try to make this an inflection point, a tipping point, we keep in mind that there are 8 recommendations. I tried to bundle them into 4. You can take them out to as many as 45 recommendations, but we've got to look at them as a group. If we just focus on scope of practice or the educational recommendations or just the leadership, we're not going to get there. And I think that's one of the critical differences, along with the environment that we're in right now, economically and as a result of the policy changes, that will let this be the moment where we can have real meaningful change. So whatever you do, when you talk about this, don't just talk about one set of recommendations. It won't get us there.
Great point.
Hi, I'm Elizabeth Jones. I'm a current family nurse practitioner student here at Penn. Just a question about, this is an issue that is reflective of the public. It's their need. And it's obviously a war that's going on between medicine and nursing and other healthcare professionals. What is the public's opinion of this? Do they know that this is going on? And if they are aware, if they are not aware, how are we going to make them aware so that they can then vote in public officials that are going to support our cause?
Wow, that's a tough one. I was saying earlier, one of the things that has disappointed me in this whole healthcare debate is that there hasn't been the kind of public outcry for change that I would have hoped there would have been. Now you say, why is that? Does that mean we're wrong, the thing doesn't need to change, or does it mean they're not well informed? I think they're being disinformed often, and believe that the status quo is better than the status quo is. So I think that there's a lot that needs to be done in the way of public education that does not come across as self-serving on the part of the health professions, but really is couched more effectively in the public interest. We do know that, I mean, from a lot of surveys, that when patients experience the kind of care that's described in this report and the kind of care that we envision that we want everybody to have, they can tell the difference and they say they want it. But when they haven't experienced it, they don't know what they're missing, I would say. When there are surveys that show when people are asked in the abstract, do you want a doctor or a nurse to be your primary care provider, the majority still say they want a doctor, but a growing minority say otherwise. But if you ask people who've experienced having a highly qualified nurse as their primary care provider, they're totally satisfied, and they don't want to give that up. So there's a difference between the abstract question and a reality-based question based on some experience. But the question is a very good one. It's one that's bothered me throughout the whole debate, that there is this disconnect between what we say we want to provide for the public and our sense, from those of us who are advocating change, that the public should not be satisfied with what they have now and what the public opinion polls tell us.
We see that a lot in the retail clinic data, by the way. Great public satisfaction on the services provided in retail clinics, most of which are provided by nurse practitioners. So as you said, there is when they have experience, there's great public buy-in for these kinds of services.
Hi, my name is Bridget Bronner. I'm currently a second-year postdoctoral fellow here in nursing. And as we're talking, I'm sitting and reflecting back on my undergraduate training as well as my first years of experience as a neonatal intensive care nurse at the Children's Hospital of Philadelphia. And one of the things that I feel was really lacking from the experience was exactly what you mentioned, that we're sort of thrust in these positions where we're expected to interact with physicians and the pharmacy and social work, but at the training level, we haven't had those types of concrete experiences just to know this is something that you call a physician for, and this is the way that you have everything prepared to interact with them, and this is something that you consult with social work for, and this is how you have that interaction. So I would just love to hear your ideas and thoughts at the undergraduate training level for how we can begin that discourse across schools and departments so that the clinical training experiences maybe become more of a collaborative model where nursing students and medical students and social work students and pharmacy students, all health professions, have an opportunity to interact with one another in ways that they will once they begin practicing.
Well, it's a great testimony. I couldn't said it better. But so it's beginning to happen, and we've got some examples now. I can say a little bit about some of the lessons learned, because a lot of people say, oh, we tried that and it didn't work. And you go back and look, well, what did you try? And a lot of them were very casual, what I would call cameo appearances, were more aimed at socialization, kind of like a mixer, rather than as a serious educational encounter. So the things that we're learning are that to do this well and to do it meaningfully, not surprisingly, like all other things in life, you got to work hard at it, you got to plan it. And it means the faculty getting together ahead of time and saying, what are the goals? How are we going to accomplish it? How are we going to measure it? What kind of feedback are we going to give? What kind of evaluation are we going to do? And it means it's sometimes taking apart what you're doing now, because the attempt to do these efforts as an add-on is generally going to fail because the students will be overburdened and the faculty will be overburdened. And it will be also viewed as extracurricular. So it does mean some fundamental restructuring, and some of the schools we're working with are willing to take that on. Not restructuring everything, and I'm not suggesting here that the whole curriculum be meshed together, but selectively and strategically deciding the content moment, the clinical experience moment, and the maturation moment that are right for planned, rigorous educational experiences together. And it is beginning to happen, but we still have a lot to learn.
But then what you'd want to do is take even the 16 places where it did work and disseminate that so that other schools can look at that and they can take that kind of model and they could adopt it. So each one of those can be a leading light to be able to show others the way in how to do this.
I think one of the things that is in the IOM report is recognition that we have new technologies to add to our curriculum development and to the way we teach students across disciplines that we need to look at for the future, whether those are using simulations or courses over the internet. Some of the constraints that were real in the past we can overcome. And particularly at a place like this where you've got the ability to evaluate your innovations and get them out, that's really what you can do to help disseminate this even further.
Okay, we have one question here, then Pat next, and then I believe we have one more question. Time for one more question after that.
Hi.
And of course, you can say anything you want.
We're in Claire Fagan Hall. You better be able to make a comment.
Whatever you want.
I want to make a comment about Risa. Risa, you are the best decision Bill Kelly ever made.
Thank you.
So to hear Claire
Hi.
praise Bill Kelly.
Hi, my name is Melissa. I'm a nurse midwifery and women's health nurse practitioner student here. My question is really about cost. When I see the idea of taking women and men who are interested in being associate degree prepared nurses and then somehow finding the funding to have them then have either a second degree program or a 4-year bachelor's degree, I'm wondering where is the funding going to come from that? I think it's very obvious to a lot of my student colleagues that we're leaving with debt up to our eyeballs and we're not quite sure how we're going to pay for it. And the idea of coming back for, a doctorate or something of that nature is kind of daunting at this time. But so I'm just wondering, you mentioned programs like the National Health Service Corps, which is certainly an extensive program, but is not available to all people for one reason or another. I'm just wondering how we're going to create all of these bachelor's prepared nurses and doctorate prepared nurses.
Well, one thing that you mentioned, I mean, you have, if in fact that seamless, efficient transition doesn't happen through education, then you're right. Even the most dogged of student is going to be going through several programs and mounting up debt. So something like the Oregon model, which says, all right, we're going in with our eyes open and saying that this is a goal. And how do we structure education so that someone can make it through more seamlessly and not rack up that kind of debt? Structure it in a way so that it can be both affordable but attainable, because otherwise it will be daunting. The federal resources that are there are not unlimited. So those that are there, making those available, but building the models that say to get there you don't have to go through 8 steps. We're actually going to go in and design ones that make that, and which is one of the recommendations, is to make that pathway much more efficient so that you add with the right skills going along into professional, adding those in. But that's exactly right. You want to look at that and make those models available.
Pat?
Hi, I'm Pat D'Antonio. I'm the chair of the Family and Community Health Division, which is producing most of the primary care nurse practitioners. But I would also like to return to the theme of interdisciplinary education, because the faculty here in the School of Nursing has just gone through a process of re-envisioning what our baccalaureate program is going to look like. And what we found, at least in terms of interdisciplinary education, it's not just what happens in the classroom. And we're really building in support to our clinical faculty who work with students on the units in the community sites where they're having the interactions with other members of the team, to build a learning in there. So we'll let you know how it turns out.
Now, the clinical education done interdisciplinary is probably, as the comment here is probably as, if not more important than the classroom, because that's really where the exchange is.
That's right. Mary Lou, I think you're This will be our last question, but you will have opportunity to talk to everybody, I believe, afterwards at the reception.
Okay, I'm Mary Lou De Leon Science. I'm the Assistant Dean for Diversity and Cultural Affairs, and I'm also a past president of the National Association of Hispanic Nurses. And this question is actually directed very much to the thread that seems to be integrated very well into the IOM report, and that is the funds that HRSA and the Division of Nursing and historically have provided, and they have been commendable. They have provided funds for building diversity in the workforce, but it's been diversity at the very basic level. And given the fact that there's such a strong need for building the numbers and also building the leadership component, there has been great opportunities historically for centers of excellence in medicine and dentistry and osteopathy, which have provided multi-million-dollar opportunities to really develop not only the pipeline and the workforce, but the leadership. But that hasn't occurred in nursing and diversity. So I'm hoping and recommending that there will be opportunities now to open up these centers of excellence in an interdisciplinary fashion so that the pipeline in diversity will be for physicians, nurses, dentists, nurses, social workers all coming together, and so that those centers of excellence can be housed in different schools, not necessarily only in one.
Well, to one point, the workforce diversity within Title VIII, and that is within the Division of Nursing, actually one of the recommendations that was implemented, one of the things that was passed in the Affordable Care Act, is that the authority has been expanded beyond basic preparation. So that is currently, so that it has been expanded to include advanced education, which can include leadership. And so that definition has been expanded. So that authority, its funding level is its funding level, but that is the Center for Excellence, which is in another part of the Park Lawn building over there. I'll find it eventually. That they, in fact, there's nothing that really precludes them. The funding is given to develop workforce diversity, and within any of the institutions, they can certainly work, and we would welcome them working broadly across professions.
Great. Well, I want to thank our panelists and our speaker, Dr. Risa. And I would encourage you to read the report. It's long, but read it. It's got great stuff in it. And I can tell you one of our recommendations has already been acted upon because Peter Beerhouse has already been appointed the chair of the Workforce Commission. Thank you.
I just need your attention for a minute longer while I thank our speakers and our panelists on behalf of all of us. We would like to extend our deep appreciation. By the way, the report looks like this, and we really have to read it. It's a very, very rich document, and it's not about, as it was said, only the future of nursing. It is really the future of healthcare. And I think you heard today, if we don't make changes and if we just think of our silos, the healthcare will continue to suffer. So on behalf of all of us, Risa, you have given us inspiration with your presentation. Thank you so much for your commitment to access to healthcare and your commitment to nursing and your compassion about patient care. And thank you for being with us today. President George Thibault, good friend, a dear colleague who really he is on message, interprofessional education. How can we get our students to learn together so we can improve healthcare? Thank you for your commitment for interprofessional education. I hope you can see that there is a momentum in this university, and I hope you can see that we really work together really well. We haven't gotten our students together as much as my dear colleague, Dean Rubenstein, and myself hope for, but we will continue to work on it. Thank you for being with us, George. Julie, thank you for what you are doing in the government. We don't want your acronyms, though. And but you brought us lots of hope about the kind of funding that's coming our way. So thank you for your leadership and for your comments today, and for all the work you have done for the healthcare reform before. We have not forgotten that. Thank you for being here today. And on behalf of all of us, to Julie Fairman, we missed you last year because you were on the train a lot, but it was worth every bit of it. Thank you for your contributions. We know, and Risa, close your ears, we know that some of the things that appeared in the report were because you were on the table there and because you brought things forth. Thank you for leading this, planning this, co-planning this, and for leading this panel. And thank you for all the work you are doing on behalf of all of us. We are inspired, right? We're going to go and do it. In fact, I think it's starting to happen. I just can't thank all of you enough for being here, for your commitment, because it does show a commitment to some changes in the healthcare system. It is, Ralph, I think it is a turning point right now. I believe it's a tipping point. Ralph is talking with Claire. So Ralph, thank you for your partnership, for what you have done in the healthcare system. But I just want to tell you, it is a tipping point. We are going to make it a tipping point, and the healthcare system will change. We're going to continue this dialogue over wine and lots of food out there. Thank you, everybody, for coming, and let's go and celebrate.